Hello dear students and colleagues, a new video, a new topic, a new concept. It's a video in hematology. Uh, Although the topic appears to be simple, but it needs some understanding. There are some concepts involved in this. So let's understand what is the topic, hemolytic disease of the newborn. As the name suggests, it's the disease of the newborn and in which there is hemolysis. So, why the hemolysis occurs and what is the probability of hemolysis occurring in particular cases and so on. Let's discuss. Now, first of all, basic fundamental is that this is the disease of Rh incompatibility between mother and fetus. So, blood group incompatible for the incompatibility between mother and fetus in womb, and that's the reason for this particular disease. Now, there are various blood group systems. So, which blood group system is particularly incriminating? It's the Rh blood group system. Later on in the video, I will also discuss whether it is possible with ABO incompatibility between mother and fetus. But let's start with the basics. So, Rh blood group is incompatible between mother and fetus. How does it all start? Let's imagine an Rh negative mother and she bears a child having Rh positive blood group. So, fetus having Rh positive means fetal RBCs have the Rh antigen, obviously inherited from the father. So, now this is the incompatibility. What happens really is, during the course of first pregnancy, assume the first pregnancy. During the course of pregnancy, there may not be much of a problem because Rh antigen of the fetus cannot cross the placental barrier. So, mother is not going to get exposed to the Rh antigen. If we just clock back a little to understand this particular concept of Rh positive and Rh negative, look, whenever an Rh negative person is exposed to Rh positive blood, it's an antigen which the person is getting exposed to, and therefore there will be antibody formation. Agglutinins are formed, anti-Rh antibodies, and there will be agglutination reaction, antigen antibody reaction, and obviously which cell will be the sufferer in this? The RBCs, because the RBC membrane was having that antigen. So, now in this case, we have assumed that this Rh negative mother was never exposed to the Rh antigen previously. For the first time, now she is bearing an Rh positive child. First pregnancy, no issues because antigen cannot cross the placental barrier. So, this Rh antigen from the fetus is not going to cross to the into the maternal circulation, and therefore it may not be harmful as such. But at the time of delivery, there is separation of the placenta. Either it's a normal delivery or while performing some obstetric maneuver, there is a possibility of feto-maternal bleed, which means some amount of the fetal blood may enter the maternal circulation. So this happens during the course of delivery, placental separation, or some obstetric maneuver, forceps application, or so on and so forth. So feto-maternal bleed, and now the fetal antigen, Rh antigen, is entering the maternal circulation, maternal body for the first time. We have assumed that this mother was never exposed to Rh antigen previously. She never received any Rh positive blood. She was never exposed to Rh antigen. This was the first exposure. So now, since this was the first exposure, there will be sensitization of the maternal immune system. The maternal immune apparatus will start forming the anti-Rh antibodies. Within next 48 to 72 hours, maternal immune system will start forming anti-Rh antibodies. So these anti-Rh antibodies, they will reach the peak titer by 2 to 4 months. There will be peak titer of these antibodies. So first baby has been delivered without any complications, without any problems. But while getting delivered, there was antigen passed on to the mother's body, and mother is now forming the anti-Rh antibodies. So the scenario is such that now mother has anti-Rh antibodies which have got developed. Now assume second pregnancy for this mother. She again has the Rh positive child. So we have Rh negative mother, but with anti-Rh antibodies formed. So there are these anti-Rh antibodies in her plasma, and now the second pregnancy also is with Rh positive child, fetus Rh positive. Note here that if the fetus second time round, the second fetus, if it is Rh negative, then there would not be any problem. Because where does the danger lie? The danger is that mother has formed anti-Rh antibodies due to the previous exposure. Previous exposure meaning during the first pregnancy and the delivery, and there are these antibodies now in the mother's circulation, and now these antibodies can react with Rh antigen. So if the fetus is Rh positive, this is the second pregnancy, only then there is a possibility of antigen antibody reaction. That is, these antibodies from the maternal circulation, they can enter the fetus body and their fetal circulation, and there would be that reaction. If it is Rh negative fetus, no problem. There is no, then in that case there is no antigen, and therefore these antibodies would not have to react with anything. So therefore no problem. So remember this, every time the fetus has to be Rh positive for this complication to develop, for this complication to happen, hemolytic disease of the newborn. Okay, so coming back to what is the danger. Look, the Rh antigen, first time in the first pregnancy, there was Rh antigen in the fetal, on the fetal red cells, but the antigen cannot cross the placental barrier. So it happened only during the delivery or placental separation that there was feto-maternal bleed, and let me tell you, even 0.5 ml of blood getting mixed with the maternal circulation is good enough to transfer substantial amount of Rh antigens. However, point was this, that the antigen could not cross the placental barriers throughout the pregnancy, but antibodies, these anti-Rh antibodies, which are called as induced antibodies, they are not naturally present in the plasma of an individual. They are induced after antigenic exposure. These are IgG type, and these antibodies can cross the placental barrier. So, from the 30-32 weeks onward, there is a real danger that the antibodies start crossing over from the mother to the fetus. We are talking about the second pregnancy now. And these antibodies now, they start reacting with the fetal antigen, Rh antigen. So, this is the danger. This is where the danger lies, that the antibodies can cross the placental barrier, anti-Rh antibodies, because they are IgG type, they are induced agglutinins. So, they will cross the placenta, they will enter the fetus, and there would be antigen-antibody reaction inside the womb during the pregnancy, later parts of the pregnancy. So that by the time of the delivery, there has been already the antigen-antibody reaction, and the fetus is born and further develops the hemolytic reaction. So, that's the disease called as hemolytic disease of the newborn. Antigen-antibody reaction, obviously, as I mentioned, which cell will be the sufferer? The RBCs, because antigen is present on the RBCs. So, fetus is born with hemolytic reaction, therefore, there would be anemia, there would be jaundice. Yes, since the RBCs have been destroyed, therefore, there is anemia, and destruction of RBCs generates hemoglobin is liberated into the plasma, and it is converted to biliverdin and then bilirubin. So, bilirubin levels rise, therefore, jaundice. So, that's the hemolytic disease of the newborn. Well, it is also called as erythroblastosis fetalis. Remember, this name is given on the basis of the peripheral blood smear. Erythroblastosis fetalis is called so because of the fact that there was hemolysis in the infant, and therefore, in reaction to that, the infant, the fetus, its organs start producing RBCs in large numbers, particularly liver and spleen, because remember, bone marrow is not sufficiently developed to produce the all the cells, 100% cells. Therefore, liver and spleen, which are capable during the intrauterine life to produce the cells, produce the RBCs, they will produce the RBCs in large numbers. Now, there will be immature RBCs. Remember, erythrocyte is a matured RBC, erythroblast is a nucleated RBC. It's a precursor of the RBC. So, a lot of RBC precursors are seen in the circulation, and those RBC precursors, the erythroblasts in the peripheral smear, give the name called as erythroblastosis fetalis. So, that is the disease, hemolytic disease of the newborn, or erythroblastosis fetalis. Remember, in each subsequent pregnancy, the chance of hemolysis and hemolytic disease goes on increasing. I mean, first pregnancy, almost 0% chance, nil chance, because I discussed the reason for it. Second pregnancy, about 3 to 5% chance that there will be hemolytic disease of the newborn. Third pregnancy, 10% or even more greater chance of developing hemolytic disease. So, every subsequent pregnancy, the chance of this disease, the probability goes on increasing. Right. Now, a few issues that need to be addressed in this case. First is whether this is possible with ABO incompatibility. Let's address this issue. Is it possible that the ABO incompatibility between mother and fetus can result in this? Well, it's extremely rare that ABO incompatibility can cause this. Why is that? It's because let's take an example. Let's say mother is B blood group and fetus A blood group. Now, mother B blood group means she has anti-A antibodies in her plasma. Remember Landsteiner's law. So, these anti-A antibodies, do they have a potential to cross over to the fetus and have this antigen antibody reaction? Well, not really possible, because these are natural agglutinins. Remember, anti-A and anti-B antibodies are called natural agglutinins, whereas anti-Rh antibody is an induced agglutinin, IgG type. These are IgM type natural antibodies, and therefore they are not capable of crossing the placental barrier, and therefore this type of incompatibility generally does not cause hemolysis. Not the probability is extremely low, almost zero. In fact, the data indicates, now this is purely on the basis of data, that if there is incompatibility of both ABO and Rh systems, mark this, if there is incompatibility of both ABO and Rh systems between mother and fetus, like mother B negative and fetus A positive. So, is there a chance of hemolysis or a greater danger of hemolysis? The data indicates that actually the chances of hemolysis become less when incompatibility is there for both blood groups. And it has been suggested that incompatibility of one blood group protects against the incompatibility for the other group, and therefore in fact, contrary to what we might feel, that incompatibility of both blood group systems might cause a greater hemolysis or a greater chance of hemolysis, that's not the case. According to the data, in fact, the chances are lowered. Okay, that's one issue that needed to be addressed. So that's erythroblastosis fetalis. Now, how do we treat it? So there are two things that can be done. One is a preventive measure and the other one is a curative measure. So preventive measure means we can give anti-D serum containing anti-Rh antibodies to the mother. Please note it. I mean, I have seen this happening in with many known doctors, that they have injected anti-D serum in the fetus, thinking that, oh, it's the fetus that is going to suffer, so anti-D antibodies to be given to the fetus. No, please note, anti-D serum, that is anti-Rh antibodies, are to be given as a preventive measure to the mother and not the fetus. Yes, this mistake is done by many doctors. So, what is the basis for this preventive measure? Now, when you give anti-Rh antibodies, what is going to happen is, you've given it to the mother, and when mother is going to be exposed to the Rh antigen from the fetus, it will coat those antigens, Rh antigens, which are present on the fetal red cells, and therefore the mother's immune system will not get sensitized. So remember, from the first pregnancy itself, in a Rh negative mother, from 28 to 30 weeks of gestation, you can start giving anti-Rh antibodies, anti-D serum, the serum that contains anti-D or anti-Rh antibodies. So the basis is, if at all fetal red cell antigen, Rh antigen, comes over to the mother's circulation, these antigens, the Rh antigens, have certain sites to which the antibodies can bind. So the anti-D serum and the antibodies will bind to those sites, and therefore the fetal antigen, even though it did enter the mother's circulation, it will not sensitize the maternal immune system, and the mother will not form the anti-Rh antibodies by herself to later on react with in the subsequent pregnancy. So that's a preventive measure. And curative measure, supposing that this was not possible, then as soon as the fetus is born, in the newborn baby, one might have to give transfusion. So auto transfusion, or the transfusion in which the fetus, the fetal blood is let out from one side, the Rh positive blood, and the fetus from the other limb is given Rh negative blood. So blood transfusion, and the treatment of jaundice is by phototherapy. So that's a curative treatment for this particular disease. Finally, are there any major complications associated with this? Yes, there would be anemia. Yes, there is erythroblastosis. So immature precursors of RBCs are in the circulation. This has got that its own problem as well in the circulation. Then there is jaundice. Well, severe jaundice can lead to what is called as kernicterus. And the other severe complication is said to be hydrops fetalis. So two very grave complications of this disorder, kernicterus and hydrops fetalis. Now this is particularly seen in the premature babies, premature deliveries, and immature infants, or rather organ systems are immature. So what's the connection, or what's the pathophysiology behind it? Look, in the premature babies with not fully developed organ systems, particularly liver is not fully developed, and therefore there is no formation of plasma proteins. You know, plasma proteins, albumin synthesized by the liver. So there is lack of albumin and plasma proteins in these babies, prematurely born particularly. And therefore what happens is, when this bilirubin is being formed after hemolysis, when bilirubin is being formed, now when it comes into the plasma, the bilirubin normally binds with albumin. Albumin acts as a carrier for this bilirubin, and this bilirubin albumin complex is a large one, and generally it cannot cross the blood-brain barrier. But now in the premature babies, if the liver is not synthesizing albumin in enough amounts, then there will be increased quantity of free bilirubin, not bound to albumin. That means this free bilirubin is now going to cross the blood-brain barrier, and it does cross the blood-brain barrier, and it stains the nuclei in the brain, particularly the basal ganglia and some other parts in the brain get stained with the bilirubin. That's called as kernicterus. So that's one grave complication of related to this disorder. And the second one is hydrops fetalis. As I mentioned, liver is unable to synthesize the albumin and other plasma proteins. You know, albumin is going to exert plasma colloid oncotic pressure or plasma colloid osmotic pressure. And this plasma colloid osmotic pressure normally takes the fluid back into the capillaries. Whatever fluid has leaked out into the tissues is taken back into the capillaries by the force of plasma colloid osmotic pressure, which is exerted by the albumin. Now in these babies, liver has not formed enough albumin, so there is no plasma colloid osmotic pressure to pull the fluid back into the capillaries. That means fluid stays out of the capillaries, and therefore there is a lot of accumulation of fluid. The name itself suggests it's hydro. So hydrops fetalis is when excessive fluid accumulates in 2 or more of the body cavities. You know, there are 3 cavities: the cranial cavity, thoracic cavity, and the abdominal cavity. So there is a lot of accumulation of fluid in 2 or more of these cavities. That's the condition called as hydrops fetalis. So these are the grave complications associated with this disorder, the hemolytic disease of the newborn. But remember, it's basically the Rh-incompatibility. The reason being that those antibodies are of IgG type, so they can cross the placental barrier, and therefore they would cross and harm the fetus, or fetal red cells will be destroyed. ABO, no probability of having this disease, but in fact both together incompatibilities, and the probability becomes paradoxically lesser. So these are some of the important aspects of hemolytic disease. Remember, if you could not give, last point, if you could not give anti-D serum as a preventive measure from 28 to 30 weeks of pregnancy, and I am talking about the first pregnancy itself, suppose it was not possible, then at least immediately after the delivery of the first baby, within 48 to 72 hours, before 48 to 72 hours are completed, you can still inject the anti-D serum into the mother's body, because as I mentioned, the sensitization of the mother's immune apparatus takes about 48 to 72 hours, and then it starts forming the antibodies. So that's a narrow window which is still available even after the delivery. But ideally, it can be given from 30 weeks of gestation onwards. Right. So that was, in a summary, the hemolytic disease of the newborn, and based on the peripheral blood picture, the erythroblastosis fetalis.